We've talked a lot about imaging over the past 12, 13 years, and we've talked a lot about PSMA, and we have wonderful lectures scheduled. So rather than getting too into, hopefully it's not repetitive. So, I'm going to try to level set first, give a high level view of where we are today, and then we'll sort of dive into certain topics a little bit deeper with a great panel of speakers, Drs. Ryder, Collins, and then Steve Rowe at 8, which he's another wonderful speaker. All right, so I think defining the why is always important, and we all know the why. We know conventional imaging is not very good. We also know that prostate cancer is going to progress in 30, 40, some articles say 50% of patients after initial treatment. So that tells us, number one, we could select patients better before they undergo definitive therapy, and we could treat them better after they recur. And then I think we all believe that there are meaningful improvements in clinical outcomes with earlier interventions, whether that be cure, overall survival benefits, quality of life, maybe RPFS. So I've shown this slide multiple times. You've seen this. Clearly, we're doing better at lower PSA levels. And this is data from some of the PYL studies. We have 4 commercially available PSMA PET agents in the US: PYLARIFY, POSLUMA, Illuccix, and Locomets. POSLUMA is the newest one that was FDA approved. I think a lot of us are very familiar with PYLARIFY from Lantheus and Illuccix from Telix, and then Locomets from Novartis, which I don't think many people are using right now. There is no data that proves one PSMA PET is better than the other. Yes, there's some nuances in biodistribution and their chemistry. Does that mean anything? Maybe, but right now I don't think we could confidently say that you have to choose one over another. But hopefully we start learning more and we can figure out how to best utilize perhaps one over another in certain disease settings that will improve performance. So if we start off at initial diagnosis and staging, this was one of the seminal articles from Tom Hope that led to the approval of PSMA 11. You see this sensitivity of 40% and a specificity of 95%. I think that's important to look at that, and we're going to talk about a little bit more about this tomorrow and focus on that sensitivity of 40%. But I think that's something for us to really keep in mind. The PYL data is very similar. You have sensitivity around 40%, a specificity of 98%. And you tend to do better as the Gleason score gets better. I think the take-home message with that sensitivity data is that it does not replace the microscope, right? So in those pre-prostatectomy trials, those patients had PSMA PET before, they went on to get surgery, the nodes were dissected, and then in those nodes they would obviously see micrometastatic disease, and then the sensitivity would obviously be lower for PSMA PET because PSMA PET it's imaging. We can't get to that same level of resolution. Maybe today we're at a resolution of 2-3 millimeters, but consistently, sometimes maybe 1, but getting into that microscopic level we're just not there. So, pre-prostatectomy, you have a negative PSMA PET, that's great. Doesn't mean there are no nodes or no metastatic disease. Or it could be positive, or it could be equivocal. And I think we're seeing some challenges, maybe not some, we're seeing a lot of challenges with bone lesions. And I don't know if I have some examples, but I think we're going to continue to get better. So this is an example of a case at initial diagnosis. You see it light up here in the left aspect of the prostate gland. Wonderful, right? You don't see any metastatic disease. Gives you confidence that maybe going forward with that prostatectomy is indicated. That being said, if you're planning to do a nodal dissection, I think you should still do that because there could be metastatic disease, micrometastatic disease perhaps, in those lymph nodes. So just something to remember. Another case, so this is a little tricky where sometimes you get it and you regret ordering a PSMA PET because you get findings that I think confound the situation more than help. And this is a case where we saw this little nodule of activity right at the dome of the bladder. The bladder doesn't show well here, but it was right on top of the bladder. And we're thinking, all right, is this Mets? If it's Mets, it's kind of an odd location. In my gut, I'm thinking, all right, it's probably not. But someone mentioned it. It was, someone mentioned it, so people are chasing it. So you get an MRI, you do all this. I think this patient even got a cystoscopy, and they didn't see anything. The MRI, I think this was from the prostate MRI, and they had one large field of view image. And you wonder, was it like a little bladder diverticulum or something where some of the radiotracer was accumulating? I don't know. But again, you're going to get some of these tricky situations, and I think it's important just to talk through it and maybe review the images with, get a second opinion with another nuclear medicine radiologist or someone else, and move forward. All right, so we're going to go on to biochemical recurrence. We've seen this slide multiple times. We're doing better. Notice that we're using something called detection rate as opposed to sensitivity and specificity, and we'll talk a little bit more about that tomorrow afternoon. But what we're seeing with these detection rates and using PSMA PET in that biochemical recurrence setting, you're seeing recurrences in places that you weren't used to seeing it in the past. And it's just something you have to get used to. And I assume most people in this room are using it, and I'm sure you have your own stories. And I think over time, we just become more comfortable seeing a lot of these. And overall, I think it's better. We'll become better. And I think it's important also to provide feedback to your imaging specialists so they can improve as well. Because oftentimes, they don't know what they called, whether it was right or wrong. And I've been wrong. I think tomorrow I'll show some cases or one case in particular that was a little, interesting. So this is some PYL data, detection rates. Again, lower PSA levels, higher detection rates. The PYL study used something called correct localization rate as well. So the side in which you called the lesion had to be correct on top of it. Just provide a little bit higher level of fidelity. All of this leads to a change in management, and I think that rad-onc perspective especially is important because it changes oftentimes the fields, the radiation fields and whatnot. Obviously it changes management for urologists as well. All right, so here's another case. We'll just sort of skip it. This is a case using Posluma from their Spotlight study. And again, you'll see multiple different areas. They called a left common iliac lymph node, perirectal lymph node. Something to be aware of is ganglia. Those nerve bundles have uptake as well. So just becoming more comfortable with that, I think, is important because oftentimes you'll see benign ganglia being called metastatic disease. So this is some data about salvage therapies. This is adjusted hazard ratios for all-cause mortality. Basically, I think it's important to start thinking about salvage therapies early. And this is another article from Louise Emmett from Australia that talked about the power of a negative PSMA PET. And I remember maybe it was 5 years, 6 years ago when, at this meeting we were talking about PSMA PET, and there was one of the urologists who was speaking who actually said if he had a negative PSMA PET in the BCR setting, he just waited for it to double and then wait for it to be positive before they actually treated. And I think it seems very different today. I think we need to be a little bit more aggressive with negative PSMA PETs, and I think it provides good data to be aggressive with your salvage therapies. So I'm going to stop there. CRPC, it's obviously used pretty much just for selecting patients to undergo radioligand therapies, and I think Steve Rowe will talk more about this. The use of PSMA PET to assess treatment response, things like that, I don't think we're there yet, so just be careful. There's always a tendency when you have a test that is much better to want to use it all the time. Try to resist that urge. Try to be a little bit more thoughtful about when you order a PSMA PET, whether it's indicated and what you plan to do with some of those findings. But I think this is a really exciting aspect of PSMA PET imaging because it's going to allow us to pick patients better and perhaps in the future also assess them better as well. Right now, we just use PSMA PET as a binary tool to say, all right, they're PSMA PET positive or negative, they should get Pluvicto or they should not. Very basic. I think we can do better, and I think we will do better in the future. So this is the table from our Radar 6 article, which is available in the Journal of Urology Open Access. It's amazing. The Radar journey has been, pretty spectacular, and kudos to Dave for really spearheading that from 1 through 7. We gave our recommendations for use of PSMA PET in various clinical scenarios. So I just recommend that you go look at this. It's interesting, again, I'll talk about this tomorrow, but in the BCR setting, we recommend using it for when you are going to do METS-directed therapy. And I think with the EMBARK data, and it really sort of creates new questions in this space. So again, I think we just need to stay up to date and thoughtful with regards to the use of PSMA PET.